It is easy to recognize signs of discouragement in a patient. You and your receptionist, your secretary, and your staff members should be alert to recognize these signs. First, a tendency toward repeated missed appointments or broken appointments is an ominous warning. If a patient is vague about making his next appointment, this too may be considered a well-developed sign of discouragement and a step in the patient's plan to quit without offending you. Weak excuses patients use go something like this. Well, I'd better call you. I'm not sure what my schedule is. Or, I'm going to have a lot of company this week, and I just don't know if I can get in. I'd better call you later. Another excuse is, I'm going out of town, and I don't know exactly when I'll be back. Still another excuse, I just have so much work to do, and this is just such a busy week, I think we'd better let it go. I'll give you a ring when I can come in. Or a patient might say, I'm going to have the car fixed, and I don't know when I'll get it back. That kind of weak excuse should make you suspect discouragement if the patient has been good about following the schedule you recommended, but has not as yet responded to therapy. The thought trend of the patient is spelled out. Don't call me, I'll call you. In our office, we have cultivated the habit of writing a lot of notes. I write notes to my secretary, and she writes notes to me. And the reason is, it's so easy to forget little things that have important meaning. And by writing a note about them when they happen, we're able to review significant points at the end of the day and do whatever is necessary about them. At the end of one busy day, I was looking through a stack of these notes concerning the day's activities. My secretary had put them on my desk. I picked up one note which showed me a clear sign of a discouraged patient, one who was about ready to quit my care. The note said, Mrs. Smith didn't want to make another appointment. Said she was too busy right now. Said she would call later. However, the note continued, I finally talked her into an appointment for Friday. My secretary had recognized that this patient's vagueness in making an appointment was a definite sign of discouragement, and thus called it to my attention so something could be done about it, as we shall soon see. Sometimes your patient will reveal discouragement by asking if you still think the cause of his condition is in his spine and nerves. He will ask if you think he will be aided by some additional procedure. Here are some typical remarks indicating this type of discouragement. Doctor, I read in a magazine that conditions like mine are often caused by deficiencies in the diet. Perhaps vitamins or calcium would help me. What do you think? Or a patient might ask, Doctor, do you think my mattress could be causing my condition? Or, Doctor, do you think heat would do any good? Or, Doctor, do you think massage or steam baths would help me? Then again, these remarks may not be a sign of discouragement. A patient may talk in that vein, yet be genuinely interested in doing everything you want him to do. That may be his way of projecting his intentions to cooperate. You, the doctor, must evaluate the conversation to determine if it means discouragement or over-enthusiastic cooperation. Here is another warning of discouragement. The patient tells you about some friend who has a condition similar to his, and he asks your opinion about the procedure the friend found helpful, or the friend is using, or the friend recommended. Now listen, you should be alert to this. That the patient entertains these thoughts suggests he lacks full confidence in what you are doing, or he has no confidence that what you're going to do will get the job done and produce the results you both want. Therefore, whenever a patient starts asking about this procedure or that procedure, You must suspect discouragement. At least he is not fully satisfied with what you are doing. Acute discouragement is apparent when the patient asks you repeatedly, "Doctor, how long is it going to be before this condition starts letting up?" You should suspect discouragement the very first time this question is asked. You can be certain that the patient is discouraged and perilously close to quitting if he asks such a question 2 or 3 times in a row. What he is doing, of course, is telling you that he feels he is not making progress. I remember a patient who was in my office recently, a big, heavy-set fellow, weighed about 200 pounds, had a chronic back condition of several years standing. I took his case history, examined him, x-rayed him, and gave him a report. I recommended a minimum of 28 adjustments. He began to improve at once. After only 3 adjustments, the pain was gone. He felt wonderful and well satisfied. Suddenly, the pain returned. I relieved him again, but again the pain returned, and I saw signs of discouragement. Even though he had taken only 7 adjustments, I knew he was discouraged when he asked me twice in a row, "Dr. Heuser, how much longer is this condition going to keep coming back?" I wiped out his discouragement by reviewing with him again my original recommendation of 28 adjustments, and by pointing out that he was already responding more quickly than I had anticipated. I told him I hadn't expected him to get any relief for at least 10 adjustments, and I explained it was natural for a joint weakened by years of misalignment to slip back into its old position. This satisfied him. My explanation of the reoccurrences, why the condition came back, removed his discouragement, and he continued on to full recovery. The wise doctor will learn to recognize these signals of discouragement. Number 1, vagueness in making appointments. Number 2, questions about additional procedure. Number 3, questions about other types of therapy in similar conditions. Number 4, frequent requests for reassurance. Learn to recognize these signals. Teach your staff to recognize them. Be alert for them. And when you see one, act in one of the ways I'm going to outline on this record. Such action will give your patient new faith, confidence, and belief in what you are doing. It's not unusual, and I'm sure you've had this happen. A patient who you believe to be getting along well comes in and takes his adjustments. He doesn't say much. He doesn't gripe. He doesn't complain. You know he's made progress. You have every reason to believe that he's coming along fine. And then you learn that he's expressed discouragement to the receptionist or secretary, and yet he hasn't said a word about it to you. What should the secretary or receptionist do? She should say to the patient, "Mrs. Jones, you know if I were you what I'd do? I'd tell Dr. Heuser exactly what you've told me. It's important for him to know at all times what progress you may or may not be making. Let me make a note here for him, and he can discuss and review your case with you the next time you come in." Thus, your receptionist encourages the patient to bring her problem to you, and she writes a note to you so you can take action to save this patient. A frank understanding between you and the patient is absolutely necessary. There is no good in trying to bury discouragement. Bring it out into the open. Never attempt to ignore it. What the patient wants is the doctor's interest and the doctor's attention on his problem. Remember that sick, discouraged patients have sick minds. They have lost the ability to make decisions, and you must move in a positive, firm manner and make decisions for them by your actions. When a discouraged patient tells you how he feels, pay attention to every word he says. Focus your mind and your full interest and attention on everything he says. He may be right in what he says, I've found this to be so. And remember this, when the patient demonstrates discouragement, he has lost confidence in you, and it's going to take more than a pep talk when discouragement brings the patient to the point of quitting. You must follow a procedure which enables the patient to develop new faith, confidence, and belief that you are the doctor who is going to get him well. When you see a sign of discouragement, always take the initiative at once. Say this, "Mr. Jones, I'm not satisfied with the progress and the response you are making." You see, you've got to beat him to the punch to maintain the controlling hand. If you wait for him to bring up the subject of his discouragement, you are automatically on the defensive. But by taking the offensive yourself, by bringing the subject right out into the open, you can control and guide the conversation in the way you wish. Take that initiative and say, "Mr. Jones, I'm not satisfied with the progress and the response you are making." That you recognize he is not responding in itself makes him feel better. It builds a composite personality. It ties you closer to him, and he feels that you know his true feelings. It builds agreement with him, and he senses your special interest in him, and he likes it. A patient who is not responding is happy to hear you say, "Mr. Jones, I'm not satisfied with the progress and response you are making." He is hoping you will change your procedure in some way that will help him. Most discouraged patients are perfectly willing to continue with you if you will make a change and indicate that you are going to work in a different way to reach the cause of the problem. But if you continue with the same therapy, the same type of adjustment, and the same old routine, you can readily understand why he is thinking of quitting when he is not responding. If you were a discouraged patient, would you continue when the same thing was done over and over and over? Sometimes I say this to a discouraged patient, "Mrs. Smith, just bear with me. We're going to work this problem out all right. You know, a lot of times there are back problems or these conditions such as you have, and it is kind of like working a jigsaw puzzle. We see a piece we think will fit into the puzzle and solve it, and we very gently and very easily try to work it into place. But then we find that's not quite it. So we select another piece that looks like it will fit, and finally we do find a piece that fits, and the puzzle is complete. It is the same way with your condition. We use a procedure which looks like it will fit. It doesn't quite solve your problem. We vary the procedure and try another approach until finally everything fits into place and your puzzle is solved. Just bear with us. It's going to work out all right." Another approach, having recognized discouragement, is to continue like this. "I've been studying your x-rays and reviewing your records this afternoon to make certain there is nothing we are overlooking." This brings to your patient's attention your genuine concern about his problem and shows him you've been spending time on his case even when he's not in the office. This gives him a good feeling about you. Then you explain further like this. "It appears that we are on the right track, even though progress is slow. However, to make certain, I am going to re-x-ray you. I'm going to send your x-rays and records back to the research clinic at my college for expert evaluation and opinion. The clinic has had extensive experience in cases like yours, and they may be able to find the cause of your slow response. If we are doing the right thing, they will confirm it. And if we need to do something additional or refer you to another doctor, they'll recommend that. Then, you should proceed to do your additional examination and x-rays based on your regular fee schedule. Most patients are willing to pay for these extra examinations and x-rays, and you should accept this to be true until the patient notifies you otherwise. However, if you believe the patient might quit because of the additional expense, say, "Now, Mrs. Jones, because you've been such a good patient to work with, and because I appreciate that, There will be no additional charge for this new X-ray and examination. Or say, we'll only charge you for a regular office visit this time, instead of the full fee for X-ray and examination. Let's see what we can find out. You're making the decision for her when you use phrases like, let's see what we can find out. Also, you can recommend additional examination and laboratory tests. Keep in mind that these examinations must be different so that you will be able to present new findings. This builds a tremendous amount of confidence, particularly if you haven't been using laboratory tests. Patients have been indoctrinated with the idea of having various tests made by laboratories. They don't expect the doctor to do everything in his own office. They're used to going to hospitals and clinical laboratories for special examinations. And actually, it's an enormous and unnecessary investment for a doctor to invest in complete laboratory facilities. I don't have complete laboratory facilities. In fact, I don't have any. I use a professional laboratory in Kansas City, Missouri, which was highly recommended to me by Dr. Rolla Pinnell. They offer complete blood and urine tests with convenient mailing tubes for specimens, and registered technicians make the tests. I recommend to build confidence in either new or discouraged patients, use laboratory facilities of this type. If you do not send films and records back to your college, tell your patient you are going to consult with another specialist in your own profession. None of us knows all there is to know about chiropractic. Here in Colorado Springs, we have colleagues graduated from several different schools, and on many occasions they have helped me solve problem cases. Occasionally, I send patients to another chiropractor for a stereoscopic X-ray of the upper cervical area. Sometimes I send them to another chiropractor for a special heart examination. I've never lost a patient yet by referring him to another chiropractor for tests or a special examination. I'm absolutely convinced that consultation elevates you in the eyes of your patient. You build the correct doctor image when, if you can't find the cause of the problem, you work in a cooperative manner with other doctors in an attempt to get at the real cause of the problem. Isn't that the kind of doctor you would want? During this examination, it is wise to question the patient about what he thinks is the cause of his condition. Often, he will give you a clue as to what he feels is needed to help him. Many times, a discouraged patient will say, "Doctor, it feels as if it would relieve me and make me feel better if you would just do this or do that." Or, "It feels like this should be done." Sometimes a patient uses expressions like, "If you'd give my leg a good jerk," or, "It feels like if you just give me a good punch right between the shoulder blades, it would feel better." I don't like a patient to talk like that, but I recognize it's not criticism or an attempt to downgrade the profession. It's simply his inability to express himself better. He is unable to express his feeling in any other way. And I've learned that I can very profitably pattern my procedure along the lines the patient suggests. Of course, I also do what I know should be done. But he is telling me in what he believes and has faith, and often he is right. When presenting new findings to a discouraged patient, my procedure is patterned after these thoughts. "Mrs. Jones, your suggestion provided me with information very helpful in guiding me during the examination. That makes Mrs. Jones feel good. It gives her some credit. And then I say, my findings, coupled with the X-ray report, show that some changes in procedure are needed. Let's go ahead and do what is necessary. Then, do what you think is right. And remember, give consideration to what Mrs. Jones feels might help, if it doesn't upset your adjustment." Discouragement can often be cleared away by reviewing the original case history with the patient. If you made thorough notes in the beginning concerning all of the patient's symptoms and complaints, it is rare indeed when 2 or 3 months' care fails to bring about decided improvement of at least one symptom. For instance, recently a patient of mine complained about her lack of progress after 3 months' care. She had a chronic back condition of many years' duration. I suggested we sit down and review her case. I gathered her records together, had her complete case history before me, as well as a health questionnaire she had filled out in the beginning. I inquired about the constipation she had originally mentioned, as well as the tendency toward digestive upsets and insomnia. She readily admitted that she no longer noticed these problems, that her bowels were functioning normally, that her digestion was definitely better, and that she was sleeping better. I asked her if her back was still severely painful in the mornings, as it had been, and if her back hurt when she sat in church. Both of these symptoms, she said, had made definite improvement, and she knew they had, and by my bringing this to her attention, she was made aware of her true progress and wanted to continue. Doctor, when you take a thorough case history, you must put down more than low backache on the case record if you want to use it later to show improvement. When taking the case history, ask questions like these. Does it hurt more in the morning or in the evening? What is it that you do that particularly aggravates your condition? Does it cause you additional discomfort when you lie down or sit down? The patient might say, well, I notice it the most when I'm bending forward. I can only get halfway down. Doctor, write that on the case history. Patient can bend forward only halfway. Later, the patient still may have backache, but notices it doesn't hurt as much when bending. If you don't take a thorough case history during the original examination, you will never have points like this to talk about. So take detailed case histories. They're a wonderful selling point. Patients are impressed with your thoroughness, and they like that attention. To give hope and encouragement to a discouraged patient, it is well to tell about another patient who had the same symptoms. Tell of his discouragement and that he was just about ready to quit, but that he wisely followed your recommendations and got well. When you ask a discouraged patient what he would do if he were to quit, it causes him to stop and think. Usually, he has no answer, particularly if he has already made the medical rounds. But this gives him a chance to unburden himself, to tell how miserable he feels. Sympathize with him, reassure him, tell him, I'm not going to leave a stone unturned in helping you back to health. Often, that is all that is necessary to make him feel better. Finally, some patients have every right to be discouraged. You may have promised the moon but delivered a piece of cheese instead. Put yourself in the patient's position. How would you feel if the doctor's grand promises for recovery were not fulfilled? You can avoid that reason for discouragement by having a clear understanding in the beginning of what the patient should expect. The best policy is, when in doubt, tell the truth. If you have doubt in the beginning, tell the truth. Make no definite promises. Have a clear understanding with the patient that you are working on a trial basis. And remember, when you're working on a trial basis, your ability is not on trial. It is the ability of your patient's body to respond, especially the spine and nerves, that is on trial. Here again are the actions to take with discouraged patients. Remember, the patient has lost confidence in your old procedure. 1. Review his original case history with him and attempt to show improvement on secondary complaints as well as the major complaint. 2. Or make a new examination and switch to a new procedure. 3. or use the new examination to reaffirm that what you are doing is right. It is always best that you recognize signs of discouragement and that you, rather than the patient, bring the subject up for discussion. That lets you control the conversation. Always agree with the patient when he admits he is discouraged. Tell him you are not satisfied either. Don't argue with him or be hostile toward him. Then proceed as I have outlined. Now, what about the disgruntled patient? He may be hostile and irritable for many reasons. Some common ones are: 1. He suspects a mistake has been made in his account or charges. 2. He suspects an error has been made in his appointment time. 3. He feels he has been rushed, that enough time or your full attention has not been given him. 4. He misunderstands additional X-ray charges or the need for further treatment. 5. He feels he was pressured by relatives or the doctor into a procedure he did not want. Handle disgruntlement this way. Keep cool and calm yourself, and the patient will calm down. Hear him out completely. Let him have his say and don't interrupt. Admit that an error might have been made. Or say, I can see why you might feel as you do. I don't blame you. And then say, but let's review together what we have done so we are sure we both fully understand the facts. Then, in a kind and calm manner, review the facts. Give the patient a face-saving device if he is wrong by saying, I'd feel exactly the same way under your circumstances, and I appreciate you coming in and discussing it. And quickly admit when you were wrong, except regarding therapy given where such an admission might be construed as malpractice. Listen to this true example of disgruntlement. One day, my secretary told me Mr. Martin was in the reception room and he was fighting mad. He really was fighting mad, too. Because of a misunderstanding about insurance benefits he was to receive, we had found it necessary to bill him. He had ignored the first bill, and we had sent him another bill. And he had ignored that, and this had gone on for 90 days. We had asked him to come in and discuss it with us, and he had ignored that. Finally, we had sent him one of those demanding letters. That brought him in. Before letting him into the inner office, I gathered his records together and had them on my desk before me. My secretary showed him in, and he proceeded in a very loud, threatening voice to tell me that my letter had made his wife nervous and upset, and that he wasn't used to that kind of action, and so on and so on. I got up from my chair and quietly and calmly said, David, I appreciate your coming in. I value your goodwill and friendship. I placed my hand on his shoulder and I looked him straight in the eye. I said, sit down here and let's review the facts. Perhaps I've made a mistake. Well, this surprised him. He had expected an argument, but my calm manner took all the wind out of his sails. Because my voice was quiet and calm, he calmed down. I heard him out, and the more he talked, the more he realized how ridiculous he was being. And finally, he admitted he should have come to talk with me, and he was very sorry about the whole thing. I told him I understood how he felt. I gave him a face-saving device to use as an excuse. I said, I'd have felt the same way if I'd been through everything he'd been through. On the way out, he apologized for taking our time, and we had saved the patient. Most disgruntlement develops over financial affairs. Working on a cash basis as we do, this problem seldom arises. The disgruntled patient who has been forced into your office by a well-meaning relative poses a real threat unless his attitude is changed in the beginning. The best way to change his attitude is to give him a preliminary spinal examination only. Then tell him that a thorough examination, including X-rays, are needed, and immediately say, I won't have time to do that today. My schedule is full. We'll just have to wait until later in the week to get started with you. Tell him to call you in a few days or tell him to make an appointment on his way out. This lets him know that you're not hard up for patients and you're not in any hurry to get started. Second, it lets him know that you're thorough and that you do things in an orderly way. Third, it puts no pressure on him and gives him a chance to decide whether or not he wants to work with you. If he calls back, you can be sure he'll be a good patient. He'll follow your recommendations. If he doesn't call back, don't worry about it. You didn't lose anything but trouble. I use this procedure with my friends and neighbors to establish the proper doctor-patient relationship. Now, a few words about the complaining patient. Nothing can make the doctor negative more quickly than the chronic whiner, the negative patient who always paints the black picture, who has a new complaint every time. She also makes the other patients in the reception room negative. When such a patient is getting on your nerves, take the initiative and say, "Mrs. Jones, I'm not at all satisfied with the way your nerves are responding. I'm going to work one more week with you, and if at the end of that time you're not greatly improved, I feel it would be wise to discharge you. I would rather not have you as a patient and fail to get results." What you are really telling her is this: if you don't cut out all the complaining and all the griping and start talking improvement, I'm through with you. This takes the pressure off you. It takes the control out of her hands and puts it back into your hands, where it belongs. Or say something like this: "Mrs. Jones, I'm not at all satisfied with the way your nerves are responding. However, I'm going to work one more week with you, and if at the end of that time you haven't shown decided improvement, I think it would be wise to hospitalize you and turn you over to an orthopedic surgeon." That's usually the last thing she wants. But if she accepts such a recommendation, you're better off getting rid of her. Another way to successfully handle the chronic complainer is to ask her if she would like you to consult with someone else. You say, "Mrs. Smith, if you'd like, I'll be glad to consult with anyone you choose to see if there's anything additional to be done." Or, if you suspect your patient would like to go to another doctor, say, "Well, Mrs. Smith, I'm doing everything I know. If you feel you'd like some additional treatment, or you'd like to consult with another doctor, or go to another doctor, I'd be happy to cooperate by making your records and x-rays available to the other doctor for review." Well, she doesn't want that either. It's basic psychology. The more you reject a patient, the more she desires your services. In many cases, you are not at all responsible for a patient's slow response and complaints. The fault often rests with the patient because he let his body become run down and debilitated before coming to you. You may ask, is it worthwhile to learn these methods to change attitudes of discouraged, disgruntled, or complaining patients? Yes, it is worthwhile. The more discouraged he is, the more disgruntled he is, the more he complains, usually the better booster he will be when he does respond. Learn these techniques. Use them. You will be amazed how quickly your discouraged, disgruntled, and complaining patients will improve. You will feel better, referrals will pick up, and so will your income.